All right. So now you should be able to hear us. Sorry, the sounds were actually off, so that's why you weren't hearing anything.
Hi, everyone. Welcome. Wow, we have so many people joining us. It's so exciting. Fantastic. Thank you so much for chiming into the chat. We appreciate that. We'll be using the chat throughout this program. So we wanted to welcome you all to the 9th installment of Mini Med School, which is very exciting. So it's the 9th session, but this is our first virtual version of the program, which is actually very exciting because then we got to invite so many extra people from across the country and around the world. So thank you so much for joining us. We're really looking forward to sharing our content and information from our local experts. Just to let you know, UCSF Fresno is the largest physician training program between Sacramento and Los Angeles, and we're very proud of it. So thank you for joining. We have a number of fantastic experts for you, including Dr. Vohra. Woo-woo! Dr. Vohra, we'll get to him later. So I wanted to introduce first the program director, Dr. Tsuki Dillon. Dr. Dillon is fantastic. We love her. You'll hear a lot from her over the next 6 weeks. She's fantastic and brilliant. Dr. Dillon earned her medical degree at Chicago Medical School and completed her emergency medicine residency training at UCSF Fresno. Yay. She currently works as an emergency medicine faculty at UCSF Fresno as well. Dr. Dillon is a Fresno native and went to Fresno State for her undergraduate education. She's passionate about community outreach and education. She's been working at the Department of Public Health since February alongside Dr. Vohra, who's one of our speakers this evening, and put together various guidelines and protocols for the Department of Public Health response to COVID-19 in Fresno County, which is wonderful. So welcome, Dr. Dillon. Thank you so much. We look forward to having you. Oh, by the way, hi, I'm Summer. I'm your continuing medical education specialist. If you have any questions, the emails will come to me, the phone calls will come to me. Call me anytime, happy to help out, but looking forward to a great series. So Dr. Dillon, did you want to kick us off?
Yeah, thank you, Summer. Summer's been great. This is our second year doing this. Actually, with me, I helped Dr. Vohra last year. This is my second year doing this, so I'm super excited. And we're very excited to have you all join us, and hopefully you'll learn a lot over the next 6 weeks. We have some really great lectures lined up. So to get started, I actually wanted to do a little bit of a fun activity. I'm just gonna put a poll everywhere that I'll share that you can join. You'll have to text a number, or you can use the link that I'll share just in a second to respond to these questions. It will just help us determine where you're coming from, and we'll have a fun question, okay? Just give me 1 second. I'm gonna share my screen. Let's do that. All right, so you should see on the top, you can text Subjeet Dill 050 to 22333, and you can join, or you can use the Poll Everywhere link. And let us know where you're from. I know the link is a bit too long, but that's the only option they gave me. Canada, Toronto, wow, okay. Selma, I like it. Spain, wow, this is amazing. Kentucky, Compton. Fresno's still winning, which of course I'm not surprised, but this is amazing. I'm glad we're able to do this virtual series because we can reach a lot more people. Yes. Texas, Seattle, Pennsylvania. I love it. I wish I could individually talk to each one of you. That would have been so great. This is amazing. Hawaii, wow, okay. I like it. Thank you, guys. Oh my goodness. So we have people from all over the place. I love it, even internationally, which is amazing. This is very nice to know. I'm going to stop this So sorry if you haven't been able to enter your answers, but this is pretty amazing, and welcome. Thank you for joining us. And Guatemala, that's amazing. Here is the next question that we're gonna do. Give me 1 second. This is a fun one. What is your most used emoji? Ellie, I like it. I love the poop. Awesome. There's some cool ones that I've actually never used before. That's awesome. Chicken. I love these. This is amazing. All right. Nice. Mine is the ghost with the stick tonguing out. It's the tongue sticking out. That's like my most common used emoji for sure. All right. So I'm going to stop sharing this. Thank you for participating, guys. I appreciate it. And I'm going to introduce Dr. Vohra so we can get started with his talk. So give me 1 second here. So I'm pretty sure most of you know Dr. Vohra, and if you don't, I'll tell you a little bit about him today. He's actually originally from, it seems like he got all his degrees in Texas initially before coming to California. So he got his medical degree from Baylor College of Medicine, and then he did his emergency medicine residency at University of Texas Southwestern, and then fellowship in toxicology at UC San Francisco. And I think that's how we recruited him to California and kept him here and never let him go again. So that's how he's here. He's actually done a lot since he's been here in Fresno. He's currently, of course, a professor of clinical emergency medicine at UCSF Fresno. I get to work with him. He's trained me over the last 4 years for sure. He's also medical director of Fresno Madera Division of California Poison Control System, and he's an interim health officer. And I hope all of you know that by now of the Fresno County. He's actually recently was awarded Key to the City award by Fresno Mayor Lee Brandt, Dr. Vohra, and the health director, David Pomova, both were awarded this, which is pretty amazing. They've done some great work with COVID-19 response in Fresno County. And they have a lot more to do. He joined right before COVID hit, so he had no time to get prepared. He joined the office and COVID just came right in, and I was like, all right, let's do this. So he's done a great job, and of course, I'm sure he's going to continue to do a great job in the coming months. And yeah, that's what I have. Dr. Vohra, take over. Here you go.
Thank you. Oh my gosh, I'm so excited. Mini Med School, so great. Thank you, Tsuki, and thank you, Summer. And everybody, all 500 of you need to just do a round of applause for Tsuki and Summer for pulling this off. This is amazing. We're all clapping. Thank you so much for doing this. This is so great. Leland, we love you. He makes this so easy for us every year, no matter if it's live or over Zoom. He's our ace in the hole. So I really appreciate this team. I'm so excited about Mini Med School. This is so great. Let me share my screen. I'm going to talk about COVID because this has been my life, my love, my obsession for the last 6 months or so. And I'll just try to walk everybody through. Can everybody see my screen now? Okay, I'll try to walk everybody through COVID-19 and public health. And hopefully some of you are rejoining us from last year. I'm not even sure who all is on who all is on our Zoom, but hopefully there's some old friends here. And if you are one of our old students that are coming back, then you know what kind of a very entertaining style I have. So feel free to, if you want to jump on the chat box, and the ladies will relay these questions for you. Otherwise, I'll just go through and just talk about the public health response to COVID in the year 2020. My associate David Lucchini's here.
Yeah, I'm just gonna say he's not entertaining. He's boring. This is official work.
I'm getting official
So
word.
I mean you in the middle. Took out the word cohort, but I think it means what you. Good?
Sounds good. Yes. Thank
Have fun,
you.
everybody.
Thank you. Great. So yeah, it's like I said, just an adventure every day. All right, we're going to talk about the public health response. So I'm actually right here in downtown Fresno at the Fulton Mall building, which was a building that I'd never even visited in the 10 years that I lived in Fresno, except to pick up birth certificates for my kids. So this is where you actually pick up birth certificates if you're a parent. And so that's what most people know us for. But there's a lot of other stuff that public health does. And I'll try to flesh out, in addition to the pandemic response, some of the other stuff that we do at public health, because that's the reason that I took this job. COVID wasn't even a thing then. Corona was just a beer. And basically, we didn't even know what coronavirus was. But I was just a big fan of public health, and I really wanted to help out because I really respect what the people here do to take care of the whole population. But now with coronavirus, we really are at the forefront of making a lot of decisions. Like that little piece of paper that David just showed me is basically how we're going to reopen the schools. So basically, big decisions get made here that no one really appreciates, I don't think. But we try to share the story of what we do because we really want everyone to understand what public health is all about and why we make the decisions that we do. So we'll just talk about coronavirus. And I just said, if I could go back in time, what are the top 10 lessons that I would share with myself back in time to just, help me on this journey? So these are basically the lessons that I've learned dealing with this pandemic, responding to this pandemic, being here in this role at this very critical time in Fresno County. I think that our county is very special in some ways, and I'll talk about that later. But I think in many ways, we're going through what a lot of other communities in the U.S., all across the U.S., and perhaps the world are going through. So I'm so glad that we have an international audience because maybe they can share what their communities are going through. But basically, this is what we have learned about coronavirus. Obviously, the very first thing that we learned was way back in January. We were hearing about a new deadly infection. And our first cases really started showing up around March. If you'll remember, around March is when we had a lot of cruise ships all around the world, and they were all reporting that the cruise ship passengers were getting sick. And so our first cases in Fresno County were from those cruise ships in Fresno residents who had gone on cruises, and then they came back with coronavirus infections. So that's how our cases were first identified. But then, other community cases kind of happened. And then now it's just being spread through the community. So it's no longer related to travel as much as it is through just community spread. And our cases went from 1 to 2 to 6 to 12. Now we're up to 26,000. And I'll explain a little bit more about the exponential spread of this illness. But that's kind of what makes it both interesting and a little scary, is because it can have exponential spread. This graph basically just shows you what our case numbers are doing. That's kind of the blue area. But then also, it's not just the number of cases, it's the number of hospitalizations. And as you can see, this blue spike was followed just a couple of weeks later by this green spike. And that's what happens with this disease is, it causes a pneumonia in the lungs. Our lecturers that are gonna be following up, Dr. Mason and Dr. Werner, they're actually gonna explain what happens at the individual patient level in the hospitals to people that get really, really sick from the coronavirus. But at the public health level, we're tracking all the cases, including those who can stay home and also those who get really sick in the hospitals. And unfortunately, some people actually go on to pass away. So out of the 26,000 cases that we've had here in Fresno County so far, unfortunately, 337 have passed away. And that's a number, obviously, that we track very closely. And I think that parallels the national experience, just in terms of usually 1 to 2% of all of the cases go on to have a fatality. So obviously we're trying to track that very closely, but we know it's new, we know it's deadly. It's deadly partly because it's new, because we don't have any antibodies to this virus. Unlike other viruses, our bodies have kind of learned how to make antibodies, et cetera. This is often called a novel coronavirus, that's part of its name. It's new. It's a new virus that human species have never seen before. And that's why it's causing so much concern. That's why we're so worried that it's going to overwhelm a lot of people's immune systems and their pulmonary systems, is because our bodies don't have that immunity to fight it whenever that infection first takes over the human body. Having said that, even though it's very new, we already know a lot about it. The fact that we know that it's a coronavirus, we've actually got the genome, we know what the protein looks like. You probably see that famous picture of all the spikes on the ball. We basically mapped out this thing quicker than just about any other infection in human history. So even though we have a lot of challenges ahead of us, the fact that we know a lot about how it spreads, what it looks like, what its RNA looks like, all of that is really good news. It means that we're on the right track to beating this thing. We've already learned a lot about how it spreads. We do know that it spreads through respiratory droplets. We do know that the further apart people are, the harder it is for it to spread. I think that's what this graph shows really well. Basically that, if you're about 6 feet or 2 meters away from someone, that it's really hard for those droplets to get to somebody unless they're really actively coughing or sneezing. But that's where, having this person's not wearing a mask, but if that person was wearing a mask, then those droplets wouldn't get over to the next person. And that's why masking is so important. We know that to some extent, washing your hands and washing surfaces that people share all the time, that's really important as well. So that basically explains why you're hearing over and over all of these messages about stay clean, wash your hands, get some hand sanitizer. I have multiple bottles of hand sanitizer right at my desk. I'm sure all of you do too. It's basically a really good idea in this day and age to be very mindful of your hand hygiene and also your respiratory hygiene, which is why I always carry this mask all the time whenever I'm at work. So I can just put a mask on really quickly whenever somebody comes into my office or whenever I have to walk down the hall. And then that way I'm not sharing my respiratory droplets with everybody else that I'm interacting with. We also know how it spreads. And so this is basically the science of epidemiology. And this is what public health is really good at, is basically they can kind of calculate all of these different numbers and calculations. One of the numbers that we really look at is called a reproduction rate. And that basically just says that for every infection, how many other people are going to get this infection. So some things are very infectious, like measles is very infectious. So for every infection of measles, 10, maybe 20 people can get infected with measles. It's a very infectious disease. Other infections aren't as infectious. With COVID-19, it seems to have a reproduction rate of about 2 to 4. And that basically means that for every case, usually between 8 and 64 cases can be created over 4 incubation periods. So I don't know if this shows up very well on wherever you're watching this lecture, but basically if you think about, one person can pass it to either one person, which means that it's an R of 1, or they can pass it to 4 other people, which means that it has an R of 4. And then if those 4 people pass it to 4 other people, and if those 16 people pass it to 4 other people each, then you can sort of see how one person can go on to give this infection to 64 other people. So that's if you have an R of 4. With COVID-19, based on the best numbers that we have, we think that it has an R between 2 and 4. That means that every single infection can lead to 8 infections or up to 64 infections over just a period of a couple of months. That basically is a type of exponential spread, and that's what we think happened earlier this summer, which is why a lot of communities throughout the US, including Fresno County, had this huge surge of cases, is because people were just passing it on to each other and we weren't able to control that spread very effectively. Controlling the spread is really done if everybody does their part and if public health has a chance to do something called contact tracing. You've probably heard this term. Contact tracing basically just means you find people that are at risk and then you basically separate them from the rest of society so that they're not spreading the infection even if they get sick. So if you think about the infected person is red, they're basically going to give it to one other person, and then that infected person can actually have other contacts. Like if that other person has 3 contacts, then you basically want to find those 3 contacts and tell them, hey, you're at risk. Please don't go move about, go to parties, go to family gatherings, et cetera, because you're going to spread this disease to other people, and you may not even know that you're sick. And that's basically what contact tracing does, is that it tracks down how people interact with each other, and then basically, gives them a good message, good prevention messaging, safety messaging, and tells them, look, you're at risk, you need to go quarantine. So quarantine basically means asking people to stay home during that period when they're at highest risk, which is usually 14 days after they are interacting with someone who has COVID. So whenever we have somebody that tests positive for COVID, we call them immediately or as soon as we can, and we tell them, look, you have COVID. We hope that you're doing okay. You need to stay home so you don't give it to anyone else. And who have you been in contact with? And then we go find all the people that they've been in contact with, and we call them and we say, you don't have COVID, but you're at high risk because you interacted with somebody who did. And because you interacted with somebody who did, we want to give you good information about how you can stay safe and how you cannot spread this to other people if you end up getting COVID yourself. So that's contact tracing in a nutshell. We spend a lot of time having those conversations here at Public Health. Obviously, people have to work. People have to go grocery shopping. People have to go out and about. Sometimes they're taking care of an elderly relative or they're taking care of their children. Contact tracing takes all of that into account and says, how can people still live their lives and perform their essential functions, but at the same time, we have to keep society safe. So how can we support these people while they're in quarantine or isolating themselves and not spread the illness around? We've also learned a lot about demographics. So demographic basically means that, you know, what are the different age categories? What are some of the other qualities of the populations that are getting sick? So one example of demographics is basically the age breakdown. You know, early on, we knew that older people were dying, but what we didn't appreciate is that young people actually get this disease as well. And that's because young people didn't have as many symptoms, and so we weren't testing them as much. Now that we're testing a lot more people, you can sort of see this age distribution, and you see that it affects all ages. You also see that young people in their teens and 20s are actually some of the highest rates of COVID infection here in Fresno County. So people from the age of 20 to 40 or 50, these are actually the most cases that we have. They're not the most deaths, but they are the most cases. And we know that those people can go out and about, that they're working, they may have families. And so those are all drivers of transmission. So if you're in that age range, even though if you're not at high risk of death, you're still at high risk of catching this disease, and you're at high risk of passing it on. So it's not a disease of just old people. In fact, that's kind of a myth that's out there, is that only old people get COVID or only old people pass away from COVID. That's actually not true. Any age group can get COVID, and unfortunately, any age group can pass away. All of these age groups are represented in our death counts as well, which I'll share with you. We do know what prevents this disease, and a lot of these steps are really low-cost steps. So even though we haven't really gotten that magic bullet cure figured out yet, we still have a lot we can do to prevent this illness. We can stop the spread of germs if we just space people out. That's why you see signs everywhere, stay 6 feet apart. Practice safe 6, as they like to say. We basically want to keep people spread apart so that even if they are masked, they will still protect each other because they're using enough space to where those respirations don't find other people, and people aren't sharing their viruses between each other. So, practicing that safe distancing, if you at all can at all times, is a really good strategy right now. That's really what I try to tell people. If you can't do that, then the masks help a lot also. And here's a diagram that I really like that just shows, the highest risk of spread between two people is when neither one of them is masked up. And the lowest risk of spread is when both of them are masked up. That's what we like to see. We like to see both people in an interaction use a mask. If both people are using a mask, then we basically say, there's a very low risk of spread, and you actually aren't close contacts with other people whenever both parties are masked up. And then that risk goes up and up if one person is masked and the other person is not masked. So just remember, wearing a mask, if everybody wore a mask, and if everybody could stay 6 feet apart, and if everybody could do everything outdoors, we would actually have a very, very, very low risk of transmitting this disease among the population. However, things break down because people do have to be indoors. They can't always stay 6 feet apart because of their job or whatever. And unfortunately, not 100% of the people out there want to or can wear a mask. And that's really working against us. So we really need everyone to wear a mask if you at all can, whenever you're out of your household. Some people do have more risk, and we do have to try to protect them. So who ends up passing away? Well, this is a table that shows of all the people who passed away, what other diseases besides COVID they had. And that includes diabetes, high blood pressure, cardiac disease, kidney disease, lung disease, asthma, liver disease. So if they have other organ diseases that they're already dealing with, and we do have a lot of people here in Fresno County that unfortunately have these chronic diseases that may or may not be getting good treatment just because they don't have their own doctor. That's who we worry about, is if they have these other diseases. I mean, a ton of people have diabetes, high blood pressure, kidney disease, lung disease here in the Central Valley. And that's just been a problem for decades. And now COVID is really just exposing that chronic, vulnerable population that we know we've had for a long time. That's something that we're trying to make inroads with, by starting a medical school here, by really getting doctors trained here. We're hoping that the doctors that train at UCSF Fresno choose to stay here like Dr. Dillon did. We need more specialists in the Central Valley. That's been a message that we've been trying to share with our community for a long time. And COVID really highlights that, is that whenever you have untreated chronic illnesses, these are the patients that actually do worse with COVID. You can see that here. These green boxes are showing all of the people that passed away who had other diseases besides COVID. And you can see that every age group has these green boxes, meaning that people with chronic diseases are represented, and sometimes the majority of people who pass away from coronavirus. We also have learned that hospitals and clinics are vulnerable in new ways. So we think of hospitals as kind of these fortresses, right? This is where you get care, that they're basically these invincible bastions of health, where no matter how sick you are, you're definitely going to get better, and anyone can just show up at any time. And we do still believe in that, but COVID has really revealed that we need to take extra care, because the number of patients that we saw, that includes COVID and also just non-COVID, that really overwhelmed our hospital capacity. And we were so worried that we set up all these tents. And Dr. Mason and Dr. Werner are going to talk about what that felt like and what it still feels like to some extent in our emergency department at Community Regional Medical Center, all over town, really. It was a really fragile time for us because we were trying to take care of people the best that we could, but at the same time, the hospitals were really struggling because we sometimes didn't have enough supplies. We didn't know, when our numbers were going to come back down. While we were experiencing this surge, we had to do everything wearing this personal protective equipment like you see in this picture on the right. And that just slows everything down. At the same time, if doctors and nurses start to get sick, then you basically have lost that workforce that's going to take care of the COVID patients. So there's a lot of reasons why hospitals, they had exposed vulnerabilities during this time. And to some extent, they still do. I think that we're learning a lot about what works. And fortunately, we've avoided some of the worst case scenarios that played out in places like Italy and New York City, and they're still playing out around the world. So we really hope that we've kind of dodged the worst of it, but we know we're not out of it yet. In fact, we won't be out of it until there's a definite cure for COVID. But we're learning all the time about what works. But we just know that, doctors and nurses, as hardworking and as spirited as we are, we've had to be extra cautious because we have to protect ourselves at the same time as we're trying to take care of other patients. And the number of patients just kept going up and up and up during the summer. In fact, it got so bad that we actually set up this field hospital in the convention center. So this picture at the bottom is actually a picture from this year of the Fresno Convention Center, which is a giant exhibit hall. And basically the military came in and gave us a bunch of beds for us to set up because we thought we would have hundreds and hundreds of patients that we would have to treat. And what's interesting is we set this up like way back in March and April, and we never ended up using it. We always thought we were going to have to use it at some point because the hospitals were so full, and they kept expanding. They kept expanding their capacity. And eventually we did actually have to use it for the wildfires, which happened just over Labor Day weekend. We actually opened up this site and we allowed people to stay here because they were evacuating from the wildfires and they had nowhere else to go. So it's interesting that we set this up for COVID overflow, we ended up not using it for COVID overflow, but we did end up using it for the wildfires, which just goes to show you the unpredictable nature of disaster response. And that's kind of how things played out. But this is kind of an eerie picture because it reminds me of the history textbooks when you read about influenza back 100 years ago. Like at the top left, here's a picture of an influenza hospital from 1918. And it looks very spooky and similar to the field hospital that we have set up here in Fresno right now. And in fact, you can go over to the convention center and it still looks like this. Here's another picture of it. It's just rows and rows of very kind of very simple cots. And it just contains hard metal cots, folding chairs. Everybody gets one roll of toilet paper and one first aid kit. It has some flashlights, just a few first aid kits, and that's really about it. It doesn't have any staffing. It doesn't have very much privacy, as you can see. There's no isolation rooms to really cordon people off who may have respiratory illness. So if you have one person with COVID and a bunch of other people with no COVID, guess what? This place is going to get contaminated, and that COVID is going to spread all over the convention hall. So that's one reason why we didn't open this up, is because we couldn't assure that this was going to be COVID-free, given the testing limitations that we experienced all summer. And even now, when we think about opening this up, we really have to think about how we're going to keep this either free of COVID, or if we are going to have COVID patients in there, how are we going to protect the doctors and the nurses taking care of them? All of these things still have to be worked out. And it's really hard to plan this stuff out because the resources are so limited, and our energy and our attention are being kind of pulled elsewhere. So we're constantly thinking about how to use this space, and it's very interesting as an exercise to go through. But between you and me, I'm really glad that we're not having to use it, because it's really not the same thing as a hospital. And I would much rather my family be in a real hospital than in a place like this, because this is just a poor substitute for what you can actually get in a real hospital, like a community regional medical center. There's other frustrating factors that we didn't predict. Flu, the wildfires, all of these things can worsen COVID-19 infection, which is a lung infection. So those are all trying to get everybody vaccinated for the influenza. So if there's one thing you can take away from this lecture, please get a flu shot. It's not too early, and you're not too young to get a flu shot. At the same time, the wildfires are really affecting the air quality here in Fresno, and we do think that that is going to complicate some people. Even if they have mild COVID, this may tip them over into needing a hospitalization. So we're really worried that the hospital numbers are going to go up because of the wildfires in people who have mild COVID illness. I really think of COVID as the tip of an iceberg. So we do talk about cases, and that's what makes all the headlines, and obviously the hospitalizations and deaths. But really, all of those things are the result of these other kind of issues that sometimes have been decades in the making. We already talked about the undertreated chronic health issues. There's a lot of economic fragility here in Fresno County, which makes people have to work. They can't work from home. They can't just Zoom because they don't have an office job. They may be working as a meat packer or a fruit packer, or somebody that has to work outdoors. They may be suffering from, just seasonal risks, like their house got burned down in the wildfire, and now they don't have a home. They may be exposed to the smoke, and now they're having to crowd with other people, and that's a huge setup for getting coronavirus. The interagency coordination, again, there's so many different people that are helping with this response. It's really hard to get the communication right. And so we're working very hard to communicate with all of the agencies and partners that we have, but it's a real chaotic situation. That's just how all disasters are, unfortunately. And that's something that we're experiencing with this coronavirus as well. And then on top of that, we just have a lot of knowledge gaps. And unfortunately, there's just a lot of misinformation. So if you're on social media, you could sort of see this for yourself. There's just a lot of hoaxes, stories, sound scientific, may not be scientific. You don't know if it's true. And we're just trying to fight through that with good information to the public, because otherwise it's like my mom, she's telling me that 5G is responsible for COVID. And I'm like, no, Mom, that's not a thing. I'm trying to talk to her. I don't know where she even found this out, but she basically was talking to her brother, her brother learned something from somebody in India. They all think it's 5G. And it's like, no, that's not what's causing COVID. But it's out there, right? I mean, it basically is making the rounds. And so we're all constantly just having to fight against a lot of the misinformation that's out there. And I think that all of that is what's leading to this moment of, it feels like a crisis. I mean, I'm not going to lie. It feels like that it's just one thing after another has built up. And we're just trying to deal with it the best way that we can. I try to have a lot of empathy. I try to have a lot of sympathy because I know people are going through a lot of these issues. And unfortunately, all we talk about is the COVID cases, and all of these other issues are kind of sunk underwater. You know, they're kind of like hidden away, and those aren't really exposed, even though they're part and parcel. I feel like COVID is just the tip of an iceberg, and really the bigger part of the iceberg, which nobody really talks about, is all these other issues that have been exploited by and revealed by COVID, not necessarily created by them. So all of these other issues have been going on for years, if not decades. The good news is we have a strategic plan, and it seems to be working pretty well. So these are the components of our strategic plan. We basically do a lot of prevention education. That's why I love talking to people like yourselves. We're really trying to get the good message out there about how to stay safe. We do a lot of updates with our media. We really try to do a lot. We have a whole communications team here. They're phenomenal. They really do try to put messages like flyers, and we've done announcements and TV ads and billboards and things like that, just to get good education out there. We're trying to ramp up testing, and we'll share how you can get yourself tested if you want, or a loved one tested for free. The testing situation is getting better and better every day. We're ramping up our team that can do contact tracing. So like I said, that's a very important component of identifying who's at risk and making sure that they don't spread the disease to other people. And that means that they need help quarantining in some cases. We're trying to look for outbreaks. So outbreaks means that more than 3 people, sometimes it's dozens and dozens of people that are very close together, all come down with the same disease. So that's called an outbreak. That usually happens when people are living close together or working close together for prolonged periods of times. So, in the jail, for example, or in a nursing home, or on a meatpacking plant where people just can't spread apart because the meatpacking requires people to interact at very close proximity with each other. So those are all areas where outbreaks have happened, and that's something that we are trying to work to prevent all the time. So every situation requires a little bit different strategy, because a jail is not the same as a nursing home, and that's not the same as a meatpacking plant, and all of those are different from schools and hospitals and colleges. So every single scenario requires a different strategy for how to prevent outbreaks, and that's what we're working through. And that leads to rational reopening. So whenever we talk about everything's closed down, and then how are we going to reopen things? Well, they have to think through what's going to happen if they get an infection. How can they prevent one infection from becoming 10 infections, which is an outbreak? And they really have to think through, for every school that opens, they really have to think through, what are we going to do when we get that first infection to make sure that it doesn't turn into an outbreak? And so we basically help them walk through those steps to do rational reopening. And all of that is part of our strategic plan. It's coming together. These are a lot of moving parts and pieces. The resources come and go. And so we do try to work with whatever we have at the time. And every day it's just a new set of issues, challenges, but also resources and solutions that people come up with. So it kind of makes it a little bit, it feels like a treadmill a little bit. Like you're always just kind of, hustling to try to solve a problem that wasn't there before. Next, basically everyone has a role to play, and that means everyone on this Zoom call, you've probably seen a lot of signs about how to stay safe. Pay attention to those signs. They really are trying to keep people kind of, getting used to this new normal. Basically doing physical distancing wherever you are, whether it's grocery shopping at the store, whether it's interacting in a public place like a park, wherever you go, people, those industries are basically tasked with keeping people safe, including their employees and the customers that use those industries. So please pay attention to them. That's why I say everybody has a role to play. Every time you choose to wear a mask, every time you choose to socially distance, every time you choose to not participate in a non-essential gathering, like a party or a barbecue or going out to the lake with your friends. That is all very important. Basically, right now, we need everyone to be mindful that anytime you hang out with other people in a way that's not necessary, you're basically putting yourself or other people at risk of transmitting this illness. And even if you yourself don't get sick and hospitalized from it, you may become a vehicle that passes it on to somebody else who's very fragile. It may be an older relative. It may be somebody else that you don't even know who happens to have a medical condition. And then they could go on to get really sick from it. So everyone has this role to play. We're all part of a community, and we need to act as a community and really keep each other safe. And it starts with just simple things like wearing a mask and keeping your distance. Reopening will happen. So we're not going to be stuck in this, in California, we call it the purple tier. Our county is right now in the purple tier, but we're about to switch over into the red tier. And these are basically different grades that the state has set up based on, how many cases do we have and how much testing are we doing. Based on the number of tests that we're doing, we're actually in the red zone, but based on the number of cases that we have, we're basically in the very, very, very light purple. We're about to cross over into red if everybody keeps doing what they're supposed to be doing. And if our good trends continue, we will actually be in the red tier. And that means that we will get to open up a little bit. We'll get to have a little bit of indoor dining. We'll get a little bit of our school reopening back on track. Like, for example, the elementary school grades. We'll get to do a little bit of, retail shopping and going to the gym and doing other things that are closed down right now. So basically, it won't be all or nothing. There won't just be a light switch that somebody flips and says, okay, go back to normal the way things were in 2019. That will probably not happen ever. But what will happen is we will gradually get to a point where, more things will be allowed. We'll probably still have to use the spacing and the masking, but, you'll get to go to the movie theater again someday. You'll get to, enjoy going to the gym someday. Basically, all of that depends on what our numbers are doing. And that's why we need everybody to cooperate and really help us get our numbers down. And the best way that you can do that is to wear that mask, use the social distancing, really stay home if you feel sick, if you have a temperature. That's why this picture is so great. It basically is, school kids are going to have to get their temperature checked, just like other employees do right now. All hospital employees, all essential workers in every industry right now, they're going through this. So even if you're not getting your temperature checked every day, if you're working somewhere as an essential worker, you're getting your temperature checked every single day because we are trying to isolate people that are sick so that they're not passing the disease on to other people. And that's something that's just going to be a part of life. So we're going to get through this together. Even if we're not standing together, we're standing apart, but we're working together. And so we are going to get through it together. I just thought this was a cool picture from the internet, but this is what a gym might look like just to protect people. And basically everybody has their own little cubicle to work out in. And that way you're not sharing your droplets with other people, even if you're not wearing a mask. Here's some information that if you want to know where to get tested or where to get reliable information, I think Dr. Dillon already mentioned the COVID Equity Project. That's where you can actually get a free test. Regardless of your insurance status, you could just walk in, there's no wait. Dr. Bond with UCSF Fresno is actually running this, this clinic, and it's a very convenient way to get tested. So please refer to that if you need to get testing done for yourself or a loved one. The Fresno County actually is doing a lot of testing all over. We do almost 2,500 tests every day all over Fresno County. And all of that information can be found at this link, or if you just Google Fresno County COVID-19 testing sites. I actually look at the CDC and the CDPH websites for reliable information. So if you just need good information about just the basics of COVID or what the rules are about X, Y, or Z industry, you can actually look at those websites. And then here's a blog called COVID Explained, which actually is a really good blog that just, again, explains a lot of basic concepts, and I actually learn a lot from that. It's very well written, and I urge you to go there if you're curious about just other questions related to COVID. And here's a drive-through testing that we're going to be doing in Reedley tomorrow. Actually, we just found out about this. The Army is setting this up, the Army National Guard. So if you're in Reedley or near Reedley, or you need to get tested, you can head over there, and pre-registration is not required. So that's tomorrow from 1 to 7 p.m. These are a bunch of horses that were rescued from the wildfires, and they're now at the Fresno Fairgrounds. So I just thought that that was a really happy, I got to go visit there, and they're just doing great. They're actually taking care of hundreds of animals over at the Fresno Fairgrounds that have all been rescued, including just a barn full of rabbits. There's like hundreds and hundreds of rabbits. And there are probably going to be more by the end of all of this. But basically, there's just a bunch of animals that are being rescued. So it's nice to see that despite all of the crisis and all of the disasters, Fresno County is a place that people really do come together to help each other. And that's why it's just a joy to live here and work here. And this just is the kind of moment that just shows what kind of a community we live in. So it's a really cool place. Anyway, thank you very much. Stay safe, stay kind, help me conquer COVID, kick COVID's ass. Thank you.
Lots of good information. We have a lot of questions in our Q&A. I can read those for you if you don't mind answering some questions. And then we have
Sure.
a bunch of people who have raised their hands, and we'll try to get through as many as we can. One of the first question is, how do you envision healthcare after this pandemic?
Yeah, good question. I think we're going to end up stronger. We're going to be more resilient. We are actually building a lot of collaborations that we hope will outlast this pandemic. I mean, what we've done for mental health resources in Fresno, what we've done for telehealth and telemedicine in Fresno and all over the US, these are all really important innovations that are going to outlast this pandemic. So if anything, I think we've learned to be more resilient and more interdependent. And more humble. And I think all of that is really going to be valuable even beyond the pandemic. So thank you for that question. That's really great.
How is the public health decision-making process affected by the system of healthcare that we have here in California or in US?
Yeah, so the state of California actually does a lot of epidemiology, and they kind of set a lot of the ground rules. So even though, I like to think of myself as like a boss, I actually am just following a lot of orders from the state, and it's actually the state that's really setting all these guidelines. Who can open, when can they open, what percent is allowed indoors for any industry. So basically, it's really up to each state. I mean, the local healthcare jurisdictions do have a little bit of, judge. Unfortunately, there's not a good national strategy, and that's really hampered, I think, the progress with coronavirus. It's often said that we're failing as a country. That's true, we are. But as two countries, we're very successful pulling each other in the opposite direction. So that's how I think of it is, we're so polarized right now that as one country we're failing, but as two countries that are completely opposite, we're doing awesome. Each one in our own little ecosystem. And unfortunately, that's kind of what we have to deal with.
How many different tests are there for COVID?
So there's the best one is the PCR, the thing that goes up your nose, and that looks for the RNA. There's also an antigen test that's coming out, and that's really appealing because that's going to be really fast. It's going to take only like 10 or 20 minutes to give you the answer. So we're really looking forward to rolling that out, but it's not really universally available. And then the antibody test is useful, but it's not really used for diagnosing acute infection. It could just tell you if you had the test, several weeks to several months ago, and it's not really worked out, so we don't really use that in our case counts.
What is the incubation period for COVID-19?
About 2 weeks. Most people are symptomatic within 5 days, but if you're good after 2 weeks of quarantine, you probably don't have COVID. So that's where the 2 weeks of quarantine comes from. That's how long it takes. The worst case scenario is that it takes 2 weeks, but most people have symptoms within 5 days. So if the longer you go through that incubation period without symptoms, the less of a chance that you have COVID.
But what about those cases, Dr. Vohra, that keep testing positive even though they meet the 14-day criteria?
Yeah, so that can happen because the test that we use is looking for the RNA. So I think of the RNA as like the cookbook and the virus is like the dish, and just because you have the cookbook doesn't mean that you've got a hot dish on your stove. And really it's the dish that is causing the problem. And so what we're doing is we're looking for the cookbook, the genomic code, And that can last for many weeks, but that doesn't mean that your body is actually cooking the dish, which is what's actually causing the problem.
Are people able to recontract the disease? Let's say I've already had COVID. Can I get it again?
Yeah, good question. We think that might be possible in a very small number of cases. I mean, there's been millions and millions of COVID cases at this point, and only like 2 or 3 documented cases of reinfection. So even if it's vastly underreported, which is possible, we don't think it's something that is going to come back and bite you over and over and over again, because your immune system probably will figure out how to outsmart it on the second or third pass. So we feel like other coronaviruses, once you have COVID, then you'll probably be immune if you have a normal immune system. But again, this is so new that all of this is just conjecture. I mean, we're going to need probably years or even decades of experience with COVID before we can say for sure who's going to get reinfected and who's not.
Yeah, that makes sense. There's a question about what can students do if they're volunteering in clinics to protect themselves and the patients and their family members when they get home? And also, what about those people who are not wearing masks? What can they do to encourage those people to wear masks?
So that's a good question. It's a gazillion-dollar question, is how to get people to actually, wear masks. I think just, having a lot of empathy and teaching by example is a good idea. More and more people are wearing masks now. It's ironic because now a lot of people are wearing the N95s to protect themselves from the wildfire smoke, but that's also helping with the COVID situation. So for what it's worth, maybe set more fires. I don't know. I'm just kidding. Don't do that. Arson is a crime. Okay. But basically, I wish I knew what the answer was to make people mask up, other than just, use science, try to explain the facts to them, try to explain how, even if they don't die, even if you're not preventing death, at least you're just getting everything back to normal sooner, so even if it's not a life or death decision, at least it's more like a gym or no gym decision, so it's going to allow you to enjoy the things you enjoy sooner if we all use a mask to slow the spread of this illness. So that's kind of the argument that I've started to use. But beyond that, that's a great question. In terms of how to protect yourself, really just follow the guidelines of the clinic. Use a mask, hand hygiene, take a shower right after you get home. Don't interact with your family before you've had that ritual of just changing and taking a shower, etc., because you don't want to bring COVID home if you can help it. And even though it's a small chance, there is a small chance that you could have it on your clothes or on your skin, and then you could pass it on to your family members.
What do you think about the vaccine, and how will that change anything? And do you think we're going to need vaccines every year like we do for flu, for the COVID?
Good question. So definitely get your flu vaccine. I think that's worth getting. With the other vaccine, that's still under development. So they really need to prove that it's effective, and they have to go through the process of the FDA approval process. But I think once the FDA approves it, that it will be something that we do want to use to protect the most vulnerable patients in our population. So it will probably be like the flu vaccine, where we do recommend people get it. And then will you need it every year? I think it's too early to tell. With some vaccines, like for example, tetanus, you only need that once every 10 years. But with the influenza, you need that every year because influenza tends to mutate every year. So we don't know where COVID is going to be between those two spectrums.
Yeah. There's quite a few questions about schools. When are we going to open schools? Why are we opening elementary before high schools, even though younger kids are more unpredictable to begin with?
Oh, good question. Yeah. So that's a. Oh, sorry, I didn't catch the last one. But with schools, we're going to be able to open up the elementary schools, I think, pretty quickly here. And you're absolutely right. Young kids are very unpredictable. I have a 6-year-old who's in the 1st grade. But the issue is, younger children actually need the in-person interaction because it's really hard for them to learn online. And it's really hard for them to learn how to socialize. I mean, obviously, all of us need that, especially teenagers, et cetera. But we feel like the elementary school kids really lose out when they're not in person in school. as soon as possible. So, you know, insofar as we can allow that to happen because we've controlled our community spread, we really do want to promote that. But then eventually, once we control spread even more, we really want to open up all schools. I mean, I do agree that, you know, everybody that's in school should have the opportunity to go back to school if that's what they want to do. And we really think that we're going to be able to offer that for middle school and high school as well. We just don't want to do everything all at once. Like I said, we don't want to turn on a switch because that's what leads to an outbreak and a surge. We really want to do things like we tiptoe into it. And we think that the elementary school kids, because they're considered a little bit lower risk in terms of complications, that they may be the ones that are going to be benefiting the most with the least harm done. But it's just it's a very good question. You know, in some cases we'll be able to open up you know, schools for the middle schoolers and high schoolers. In other communities or counties that are still experiencing widespread infection, they're going to have to wait a little bit longer. So even across California, there's some counties that are going to be able to open up their high schools and middle schools earlier than we are here in Fresno County.
I think this will be the last question, unfortunately. We'll try to get through. I know there's some really good questions.
Oh, yeah, no, these are great. These
are
really great questions.
There's a question about sequelae of COVID. So if somebody was to get COVID, and what are the sequelae after you get COVID? And if somebody did permanently lost?
Sorry, I didn't catch the last question. It sounds like just long-term complications of COVID. Mm-hmm. Those are now being described. It's a little scary. Obviously, it's all very new, but there are some people, they're called long haulers, that just tend to have prolonged manifestations of COVID. And that can range from just chronic fatigue to really bad pulmonary function testing to kind of weird stuff that's kind of like they don't get their sense of smell back. You know, so that's one unusual thing about COVID is that you lose your sense of smell and taste. And there's some people who just don't get that back, maybe because they've had some inflammation or some damage to their nerves, and that takes a while to come back. I wouldn't say lose hope. I think it's so new that, you know, it's hard to say that anything is permanent, but we do know that some people have months and months of symptoms, and maybe, you know, the medical science will catch up to them and they'll find a cure for those symptoms. But there are, just with any virus, there's some people that just have a prolonged course. And that's shown even with like things like chickenpox and other viruses. There's some people that just have a longer, more complicated course. And so it's not surprising that COVID patients, there's a very small number that have that too.
There's one question about Fresno and Clovis allowing some of the sports to be happening at this point, even though we're worried about infection rate in teens and students. Yeah,
so we're allowing some of the school sports to start their conditioning. We're not at a point where we can allow games because games would be too much interaction. But we do know that, you know, people do need to be doing conditioning for their mental health and their physical health. And so there's some guidance available that we're working with the schools on about how to get that done. And so that's kind of where we are. But again, all of this depends on the public. You know, as long as the public is able to help us get our numbers down, then we can move into the red tier. And once we get into the red tier and into the orange tier, we will be able to allow more games and group activities. So it's really up to all of us to really protect each other and get our case counts down low enough to where we can then restart some of these other activities.
Right. I think that was great. Sorry if I didn't get to your question. Those are some really, really good questions. And hopefully this helped.
Yeah, no, this is great. Thank you all.
Thank you, Dr. Vohra.
Totally. Fantastic. Thanks, everyone.
Thank you. I am going to go ahead and introduce our next two speakers who have a great talk planned. So I'm just going to do a quick intro for them. I'm going to start with Dr. Jessica Mason. She's one of our faculty at UCSF Fresno at this time as well. She actually earned her medical degree at University of Southern California Keck School of Medicine, and then did her emergency medicine residency at Metro Health Medical Center and the Cleveland Clinic in Ohio. And then she did her fellowship in medical education here at UCSF Fresno, and then decided to stay on as a faculty. So Fresno recruited another good one. She is a great mentor that I worked with in the emergency department. She's done actually quite a bit of work in medical education, especially with emergency medicine. So if you've ever heard of something called MRAP, which you might not have heard of, it's a podcast, really, really good for emergency medicine physicians or medical students. She has actually directed a lot of different contents for it. So she's done the board review for it. She's done various video productions, which are basically usually involve various different procedures that we do in emergency department. She's actually created videos to teach other people how to do them properly, which has been really useful for me as a resident throughout my training. And then she's actually right now involved in writing. She's I think associate editor for Corpendium, which is actually a book that MRAP is writing right now that's gonna have all the up-to-date information. It's gonna be updated all the time. It's an online book. So it's never gonna get old because it will get updated with time. So it's pretty nice. So that's Dr. Mason. And I am gonna go ahead and introduce Dr. Werner as well, and then they can say hello to you. Dr. Werner actually earned her medical degree at University of Maryland School of Medicine and completed her residency at Brown University in Rhode Island. She is currently a medical education fellow here at UCSF Fresno. So thank you for coming to Fresno and joining us. We appreciate that. She's actually a vice chair of EMRA Education Committee for this and next year, so this academic year basically, which is pretty amazing. And she's actually a regular contributor of EMRAP. She's worked with Dr. Mason before, and she's a co-host of EMRA Cast, which is another emergency medicine resident associate cast. So it's basically a podcast for emergency medicine students and physicians to learn more about us, to regular updates that we go through, and just another education platform, which has been really, really helpful. All right, I hope I did that okay. So I'm gonna go ahead and let you to introduce yourself and get started.
Thank you so much, Dr. Dillon. Like Dr. Dillon said, I'm Dr. Mason. It's really a pleasure and an honor to speak to all of you. I wish I could see your faces because I know there's a lot of you out there right now, and you're here and you're taking time out of your life to learn about medicine, and I think that is so cool. I got to speak to this group a couple of years ago, and just learning about who is in the audience is normally something I like to focus on. But I know there's lots of people who are really engaged community members, and also people from outside of our area who are learning from our group tonight. So thank you so much for joining us, and thank you for inviting Dr. Werner and I to speak to you tonight. So Dr. Werner and I wanted to talk again about COVID, and we hear a lot about COVID. Actually, it's basically all you hear about constantly around the clock for months now. And we heard that great presentation from Dr. Vohra. And I learned a lot by listening to Dr. Vohra, and his angle was a little bit more of the big picture on what's going on and what does this look like from a public health perspective, and what does this mean. And we want to zoom in now for a few minutes and talk about an individual person. Talk about you. Let's talk about a single person who comes into the emergency department. What is that experience like when you have possibly COVID, you have symptoms of COVID? And we want to talk about that from your perspective as the patient. And we also want to talk about that from our perspective. And we want to share with you some of the things that we think about when people come into the emergency department. You have your set of concerns, we have ours, and sometimes those don't always get translated to each other. So that's what we wanted to focus on. Now, before we get into that, we wanted to talk a little bit about just some perspective on how we got to where we are now. So back in, I guess this started February, March, and we'll go through the timeline in just a moment. There was this intense spotlight on the medical community. like nothing that we've seen for a very, very long time. Certainly nothing in my career, in my lifetime. There has never been so much scrutiny on medicine and desperation with this deadly virus going around, this feeling of the public being desperate for answers and feeling scared, and for physicians and researchers also feeling desperate to share information as rapidly as possible, because we need to share information so that we can learn from each other's experiences as people are dying. So never before has the media, I mean, when else does you turn on the news and you hear about medicine every single night? I've never heard of this before. And there's just such an intense scrutiny and intense focus on medicine in the media. This led to, I think, some interesting things happening. In the way that COVID was handled and is being handled, especially in those early couple of months, there was that desperation to share information. And normally in medicine, before we share information, a research study gets done. It gets reviewed by peer reviewers, and they weigh in on whether or not they think that information is good and valid and we should share it. And then it gets published. And then that published information gets disseminated and discussed and shared. Now, because there was all this pressure to get answers fast and to share knowledge as fast as possible, at times that pressure led to some of these checks and balances being passed over. Like, a lot of papers were published before peer review. So pre-publication, pre-peer review, just get the information out there. And as that was happening, a lot of information got shared, and some of it was not good information. It was the best that we could share because it's what we knew at the time, but some of it was not good. And so you have this iffy quality of information being shared at a rapid pace with intense media scrutiny, and everyone feeling desperate to try to get answers. And I think that I just want to put that into some context, that that's what it felt like for us on the inside, and trying to figure out how to interpret this information and to do it on a really, really fast timeline.
As Dr. Dillon and Dr. Mason said, I'm Jessie Werner. I'm so happy to be speaking with you all today. I'm an education fellow at UCSF Fresno. I'm going to review with you now the timeline of this virus, because I think now that we're in the thick of it, it's been many months. It feels like we've been living in this for months, years, some indefinite period of time. And it can be hard to remember back to February when all of this was first starting up. So we've actually broken the timeline down into, it's a visual representation of sort of how it felt. So Dr. Mason's going to start by talking about February. We'll break it down month by month.
So, and forgive us if we don't have this exactly factually correct, but from what we can remember, what we knew back in February, we knew that COVID is a virus. It's a novel coronavirus that started in China, and it's starting to spread. It's causing a lot of really concerning illness in China. It's spreading to other countries. We don't know yet if it's going to hit the United States. We don't know how severe it's going to be. We really have no idea. The only thing we can compare it to is SARS, the original SARS-CoV-1, and MERS, which are similar types of viruses, but they didn't break out into pandemics across the entire world. So February is sort of a big question mark, and people are starting to get concerned, but it's unclear exactly how bad it's going to be locally for us.
Then we moved into March, which in the medical field hit us really hard. And that was the month that we were not just bracing for the virus, but trying to accommodate the multitude of sick patients who started flowing into the hospitals. And I'm sure many of you remember what was happening in New York City. Italy was being hit particularly hard. Across the country, we were trying to learn everything that we could about this virus as quickly as possible so that we could adequately treat sick patients. We started to realize that there were certain patients who were being hit harder than others, particularly the elderly, people with medical comorbidities like diabetes and obesity. we realized that this was a very severe respiratory virus, and patients were needing the ventilator, which is the machine that helps you breathe when you can't breathe well on your own. And hospitals were panicking because we were running out of ventilators. In addition, we were running out of the supplies to place patients on ventilators, put the tubes that we need to put into the trachea to breathe for patients, the equipment we need to place those tubes. So the supplies were in short supply. Furthermore, physicians were running out of protective equipment. PPE, personal protective equipment, was also a huge issue. We had never faced a situation where we needed to wear so much equipment all the time, every single day. And a lot of this equipment was only designed for single use. You would wear it once and you would throw it away. But now we were faced with patient after patient where we started to have to re-wear our equipment, not just for days, but for weeks and months on end. And we were trying to find ways that we could do that safely without getting our staff sick. We started to learn a little bit more about the virus. We started to explore ways to test for it. And a lot happened in March. We're going to move into April.
And we've stretched out the timeline here because this is kind of how it felt. You know, March felt long. April felt very long. In April, we see that not only has COVID hit certain parts of the United States like New York, but it's hit very, very hard. And it's crippling the medical system. They're surviving, but it's very, very, very difficult. And as they get this huge influx of patients, people start to realize that some of the things we initially thought were true maybe aren't true. So we do know that COVID causes a really bad type of pneumonia where you need to be on the ventilator. And the early thinking was put patients on the ventilator early. It's going to be better for them and better for everyone if they're ventilated early. Now we see a shift in April, and we start learning about this alternative strategy, which is a total 180. Do not intubate and ventilate patients unless there is no other way to keep them breathing and to keep their oxygen levels high enough by no other means. So we start trying other things. High oxygen flow through the nose, for example, certain types of masks that deliver high oxygen contents and help patients breathe. I don't know if you've heard of something called awake proning. Have you heard of awake proning? Prone position is laying on your stomach. So supine's on your back, prone's on your stomach. And just this simple maneuver of patients who are not having high enough oxygen levels, having them lay on their stomachs for a little while is helping to open up different parts of the lungs. So we're seeing this shift in how we manage COVID. We're also starting to explore medications, and this is when those studies started coming out about hydroxychloroquine and azithromycin. It's really unclear if there's really any validity to these medications, but they're all over the news. The cat is out of the bag. These are out there. We also learn about COVID-related illnesses. So not only does COVID cause pneumonia, but it seems that COVID increases your chance of forming blood clots that can cause heart attacks and strokes, and blood clots in the lungs called a pulmonary embolism. So all of these sort of related illnesses we learn are all tied to COVID, and there are way more, far too many to mention. So we start developing strategies to take care of not just COVID, but all these secondary effects and secondary illnesses of COVID. And then we also get a study about remdesivir. We start hearing about this antiviral medication called remdesivir, first in April.
In May, we started to realize that the medications we initially thought were useful for COVID actually not only were not useful, but may be dangerous. And those in particular were hydroxychloroquine and azithromycin. So that came about in May, and we started looking more towards remdesivir as a possible drug for use, and it became available across the United States and the world. We also found asymptomatic carriers of COVID. So you may have heard of super spreaders, and these are people who have the virus. They a lot of times don't even know that they have the virus. They may be asymptomatic and end up spreading it to large groups of people. And a classic super spreader is actually kids. Kids tend to be super spreaders. They have the virus, they don't know it, and they end up spreading it to large groups of people. So there are asymptomatic carriers.
And then just to sort of accelerate us through here, June, we start hearing about something called convalescent plasma, which is drawing blood samples from people who, more than just a sample, actually a bit of blood, from people who have had COVID and recovered, and then filtering out all the cells. So you have basically just the liquid the blood was in, and then using that as a potential treatment for treating other people who have COVID. So basically trying to bring in all those antibodies and immune cells from someone else into a new patient. So we learn about convalescent plasma. And then I've mashed these other months together because it felt like July, August, and September just were all sort of a blur. And there was this massive amount of information that came out March, April, May, June. And now it's sort of tapering off. Now we're in sort of this other phase, it feels like to me, where now we're focused on vaccines. And so it was this huge, dense amount of information at first, and now it seems to be slowing down a bit.
All right. If you have any thoughts on any of this, feel free to talk to us in the Q&A or the chat, and we will try to answer these questions for you. I do see one question that says, I see a lot of people wearing face shields instead of masks, and what are doctors' opinions? And I can just start with that. I think the more protection, the better. So if you're wearing a mask and a face shield, that's probably a good idea. If you prefer to wear one or the other, that's, you know, adequate. I don't know if the other physicians here have other things to say about that.
So that was a sort of a somewhat recent addition to the mask. So you should wear a mask out in public. And then the question was raised, well, what about protecting your eyes? And perhaps a face shield or some goggles would be helpful. And I think you have to take your own risk assessment into account. If you feel like you're a high risk person for getting very sick from COVID, then you should consider adding that on. We'll be monitoring the Q&A the best that we can as we move forward here, and monitoring the chat the best we can. It's a little bit hard to do both at the same time.
Dr. Mesa, there's one hand raised. I'm going to allow them to talk, Haley Avila, and let them ask a question if that's okay with you.
Yes.
Okay. All right, Haley, go ahead. Maybe her hand went down actually. So let me see.
Okay.
Right. Haley, if you don't mind typing your question in the response, that would be great. And I think, and we'll just answer them at the end if that's okay.
We'll come back to it.
Yep.
Great. So we're going to move on to the doctor-patient interactions and sort of address the expectations versus reality. This photograph is what we as physicians, and probably you as patients, would ideally like to see. We want to be in a private room with you, sitting down, talking about what's going on. We want to have that time with you and really have an intimate experience. Unfortunately, COVID has really changed the way that we get to interact with our patients. And we're curious, you know, as we show you these pictures and we talk about the way that COVID has changed the way that we see patients, we are curious to hear your thoughts. So please write to us in the chat and let us know if this is what you expected or what your sense of reality was.
So if you came to the emergency department where Dr. Vohra, Dr. Werner, and I work, you would see something like this to start with. And this is not unusual. This is a lot of emergency departments across the country, probably across the world, who have similar setups. You would not walk into the emergency department. In fact, this is the parking lot where a bunch of tents have been set up. And they've been up there for months now. And you would get checked in at one tent and you would get asked about your symptoms. And if you have symptoms that could perhaps be related to a COVID infection, you would be sent to one of these tents instead of being sent initially into the emergency department. Of course, anyone who appears very ill or has abnormal vital signs, someone who needs a resuscitation, like doctors and nurses immediately, will get sent in. But if you're stable and look well enough to be evaluated from the tent, this is where you're going to go. So you'll walk down, you'll get brought in. This is the inside of one of our tents. They're very high tech. That's an X-ray machine that you're seeing on the left. And then behind it in that little room, there's an EKG machine. And just further down that hall, that's where the nurses are set up to do their triage assessments. So you'll get brought into here. And once you get triaged by the nurse, you'll get sat into this little space, which is actually a shed, and it's been set up with a chair and an iPad. So we have a group of these sheds, and a doctor will probably visit you initially on an iPad and talk to you that way and do the initial screening. Make some decisions about if you need testing or not, if you need to be seen in person. And sometimes you'll see a doctor in person. That's me in the tent. I like to go in the tent because I feel like I gain so much by seeing the patients whenever possible. So that's, you can see what I look like now. You can see what I look like when I'm in the tent, when we're actually face to face. And it's a very different experience for us, and of course for you, that this is now how you interact with a doctor.
And you can imagine, you can see that we're wearing face masks and you're wearing face masks, and you know how hard it is to talk to someone when you're wearing a face mask. It's hard for them to hear you. It's hard for you to hear them. And as you might imagine, being in a loud tent with a fan on, it does change the patient interaction. And it's frustrating for us as providers. We want to be able to hear what you're saying and have a very close interaction with you. And the masks and all the gear that we're wearing does make it challenging. And I do see something in the, so we're interested to hear what your thoughts are. What do you think of when you see these photographs? Is this what you expected? Is this what you thought would happen? And I do see something in the chat here. It says, it really does shift the interaction between healthcare providers. I started to do video calls, and even then it felt like I wasn't getting the service I needed, or at least was used to. I had to send my vitals online, but I didn't have the equipment to take them. I feel like you're more likely to be seen sooner, so definitely a give or take situation. So it's saying that you would be seen sooner if you did a video call than if you went into the hospital. So, and that was, thank you, that was from Karen Abigail Matulik. I think that's an interesting point that you make. One positive shift, perhaps positive shift of COVID, is that now there's more video appointments, and some people do like this because you can be in the comfort of your own home and you may get an appointment sooner. But there's other complications with that, which is that you don't have someone there taking your vitals. They're relying on you, and you don't really get someone touching and examining you in person.
My thoughts on that. So I've also been on the patient end of these telehealth visits, and I've at times really liked them. But I can tell you though that there are times where it works when it works, easy when it's easy, and all the other times you need that in-person interaction to solve a problem. So that's why I like going into the tent whenever possible. Sometimes the calls are very easy. I see a very well person with some mild symptoms, and we're going to do a swab and that's it, and then they're going to go home. And that's great. That's what the iPads are there for, having that simple interaction and sort of moving on. But sometimes someone has a complaint where you just really you don't know if they're safe or not to go home until you go in and listen to their lungs or do an abdominal exam. So it's easy when it's easy, but it is not always easy to do telehealth. And it really has changed things for us too. We feel it too. I think we miss the way things used to be just as much as our patients do.
We really do. We did not go into medicine to talk to people over the computer. I can tell you that. We all like interacting with humans. And there's a couple other notes in the chat. I won't take up too much time, but just some things I thought were interesting. Someone mentioned that it's especially hard for people who aren't very good at technology or who don't know how to use the computer very well, that there can be challenges when people don't speak English, or if there's a language barrier, that's sort of an added difficulty, especially with the masks. And some people are just sort of saying, I don't like not having someone there in person. So we really appreciate all of your feedback. Thanks for writing to us in the chat here.
So we want to walk through a couple of cases now. And before we go into these, I want to say that, one of the ways that I commonly teach is by doing recordings, whether it's an audio recording or a video recording of patients who are willing to participate in that process for the sake of learning. And so I wanted to bring that style of teaching to this talk today. So you're going to see two real cases, and I need to acknowledge and thank the two patients who were willing to be part of this. There's 2 patients who, as you know, when you go to the doctor, it's a very personal experience, and to be willing to share that with other people for the purpose of education is a really wonderful thing and a wonderful gift that they've given us. So I want to acknowledge these 2 wonderful patients, and of course we have their consent to show these videos. So let's start with our first case, and we'll be asking you some questions after we play the brief interview about your thoughts on his case. Tell me what's going on. What brought you to the ER?
I was diagnosed with COVID on the 1st. I was treating it with this vitamins and tonic water and stuff, and Tylenol and Mucinex. I was feeling okay until today, where I was laying down and had shortness of breath on the couch. Got up, felt a little woozy. Got my O2 meter, checked myself, and it was 87 to 88, and decided I need to come to the ER.
Okay. Do you have any other symptoms?
No.
So you're feeling...
I had a slight fever this morning.
Okay.
And, no.
You're feeling short of breath now?
A little bit,
Yeah.
yes.
Okay. Do you feel more short of breath if you're walking around or doing something?
Walking, I assume it was really bad.
Yeah. How about cough?
I haven't coughed since I've been here.
Okay.
Yeah.
Have you been coughing the last few days?
Yeah.
Okay. And you got your test done, it would be about 4 days ago, is that right?
The first
5 days ago.
5 days ago?
Yeah.
Yeah.
Okay. Any chest pain?
No. Like a pressure, but not. I wouldn't call it pain.
Okay. Now these are his vital signs. You could see on the sticker on his chest, you saw his temperature there, which was normal. He did not have a fever. And there it showed his oxygen was, I think it said 95%. Normal would be like 98, 99, 100. So slightly low, but we don't get terribly concerned about that number of 95%.
So just to give you a sense of what we're thinking about as a physician when we talk to a patient like that, the first thing that we're thinking about is, how are they talking to us? How are they speaking to us? Does he seem breathless? And I would like to ask you all, what did you think about this patient? What did you think about the way that he was breathing? If you were this patient, would you have come to the emergency room? So what we think about is, how do they sound while they're talking to us? Can they finish their sentences, or are they running out of air? What does his skin look like? Is he sweaty? Is he dry? What do his eyes look like? These are all things that we try to take in the first few minutes when we're talking to a patient. And we're interested to hear what your thoughts are on this. And I do see someone said, yes, I would have come to the emergency room because this patient was short of breath. And other people are saying he does seem breathless. He's gasping for air. But someone mentioned, I'm not sure how much of it is because of the mask. And that's a fair point. The masks can sometimes make it seem harder to breathe. I will just say, though, that it shouldn't be quite this bad. You wouldn't be noticing it like that if someone had normal breathing and was wearing a mask. If I was that patient, I would definitely go to the emergency room. The gasping is something to worry about. I think you're all noticing that from the video, and I would agree with you. Yes, I would go to the ER. Everyone is agreeing with us on this. Mm-hmm. Yes, it seemed like he was having some trouble talking. I definitely would have gone. He was struggling to talk. Yes, those are all things that we would notice as a physician. We're noticing that as well. It's concerning.
I also want to point out something very smart that this patient did. And he told me in more detail that his sister-in-law is a nurse. And when he got told he had COVID, she recommended that he buy a pulse oximeter from Amazon or wherever that you put on your finger, and it gives you a little reading of your oxygen percentage. And he at home was getting readings in the high 80s. And his sister-in-law said, that's too low, you need to go to the ER. That's very smart that he was able to buy a pulse oximeter and to monitor himself at home when he was feeling short of breath. One of the things that COVID does that's very bizarre, and I don't know another illness that does this, is it causes a very low oxygen concentration. And yet a patient may not have symptoms that match how dangerously low their oxygen can be. So it's not the case with this patient, but in many cases, you may see someone with an oxygen level of 50, which is normally a crisis. We're normally putting in breathing tubes and putting people on ventilators. That's absolutely dangerous. And yet they're sitting there talking and they look out of breath and they say, I feel out of breath. But that number is not normally what we see with people who are awake and talking to us. So you don't know if you have COVID, if your oxygen level is dropping down. It's really hard to know if you don't have a way of measuring it. You look for these vague symptoms like he has described, of feeling short of breath or feeling more tired or feeling dizzy. So it was a very smart thing that he did. I think I agree with everyone. These are concerning symptoms. At the same time, he doesn't look like someone he looks like he could have been in the tent. That would have been okay. He doesn't look like he needs to be in one of our, crash rooms where we're doing all these emergency procedures. He looks okay, but not great.
And Dr. Mason, people in the chat are just sort of expressing a lot of surprise at the level of 50% seeming extremely low, and that people are still awake and talking, and sort of asking why that is. And I will just say that it has been very surprising for us as providers to experience that as well. We've never seen that before. We didn't really know that was possible. We're seeing patients who are sort of comfortable with hypoxia, meaning that their oxygen level is not normal and they don't seem nearly as uncomfortable as we would expect them to be. And we don't really know why that is.
I don't know of any other illness that causes that phenomenon of very low oxygen levels and yet people who are awake and conscious. And that's one of the scary things about being well enough to go home with COVID. You don't know what your oxygen level is, and so you have to sort of monitor for these vague symptoms or find a way to check your oxygen to see if you're becoming one of those entering that danger zone. So a number of tests were ordered for this patient: a chest x-ray, lab tests, an electrocardiogram or EKG, and we're going to look at some of these. And so starting with his chest x-ray, what you're seeing now is a normal chest x-ray. So you can see the borders of the heart. You can see all that sort of black, dark gray space. That's the lungs. We like it to look dark, black, because the x-ray beam should fly right through that. It's not getting stopped like it's getting stopped on the bones of the vertebrae or the ribs that you can see the outlines of. So that's a normal chest x-ray. And here is our patient's chest x-ray. So here you can see what we call this sort of patchiness that you see on both sides. This is COVID pneumonia. It can look a lot of different ways, and this is one of the ways that it can look. So it's not just affecting one part of the lung like we see in more typical forms of bacterial pneumonia. It's patchy, it's on both sides, and it's a little bit everywhere, all over his lungs. So that does not look like a very good chest x-ray.
Now we're just going to review an EKG. So any patient who has any complaints of chest pain or chest pressure, as he was describing, any patient who has an abnormal vital sign, especially an abnormal heart rate where it's tachycardic and a little bit fast, we would order an EKG. And these are difficult to interpret. It takes a lot of time. But there's a couple things that we noticed when we ordered this EKG. In addition to him having a mildly fast heart rate, we also saw that he had some signs of indicating some damage to his heart, that his heart might not be getting the proper oxygen supply. So what we've circled here in blue, you can see that little wave that's going down and then going up. That's abnormal. We wouldn't expect to see that there in an otherwise young, healthy person who had no signs of a heart issue. So that was concerning to us. We were wondering what was going on. And a lot of times in patients who have an abnormal EKG, we'll order a second one to see if anything is progressing. So in this patient, we did order a second EKG a short time after. And now you'll notice on the other side of his EKG, it looks different. Now you can see that there are several areas where the little wave is sort of a U shape. It's a dip, not only on the left side of the screen, but also on the right. And so this is called a dynamic change. His EKG is progressing and showing us that he's having ongoing damage. There's something going on with the heart that shouldn't be happening. So he's having some stress on his heart from the virus.
And that was also reflected in his lab tests, which also the markers that we check for stress on the heart were also elevated a little bit in this patient. So let's pause here and ask the audience, what do you think? Should this patient be admitted to the hospital? Or do you think he's safe to go home?
I see yes, yes, everyone says he needs to be admitted. Admit, hospital for sure.
Mm-hmm.
You're all physicians now, yes. Good job. Hospital, yes, everyone says hospital.
So, so the other things that were ordered for him, we talked about his chest x-ray, his EKG, lab work was ordered, and that's sort of the overview of the results. Abnormal EKG, abnormal chest x-ray, abnormal labs. So you're all right. He does get admitted to the hospital. And despite how he looks, because I would say he looks a little out of breath, but not that bad, he actually stayed in the hospital for 10 days, diagnosed with COVID pneumonia. He was started on remdesivir, which is that antiviral medication that might be helpful. He was started on a medicine called dexamethasone, which I've misspelled there, but that's a steroid medication that may help with patients who have more severe forms of pneumonia. He's also found to have this diagnosis, rhabdomyolysis, which is a muscle breakdown, and that can leak out into the bloodstream and can affect the kidneys. He has cardiac effects. So he really has a lot of systems in his body being affected by COVID. Now the good news is that after 10 days, he completed his antiviral medicine. He no longer needed oxygen. He was able to go home. He is feeling much better. I talked to him on the phone yesterday. He is back at work. He says he feels back to normal. The only thing he said is residual is some tingling in his fingertips, which I cannot explain. There's a lot of things we don't know about COVID. He said his wife still has the same thing too, with the tingling in the fingertips. So we still have so much to learn about the ways that COVID affects the body.
And there's some questions about smoking. Smoking does put you at increased risk for complications. But we've seen otherwise young, healthy patients also be hit really hard by this virus. So it's just hard to know who is going to have a bad or, challenging course and who's not going to.
So we're going to quickly listen to the next case. And before I play this one, you can note that the sticker on her shirt is her temperature, 101.9. So that is a fever. So now let's take a listen to what she has to say.
And then before I ask you any questions, it's okay with you that I'm doing this recording to use it for teaching? Yes. Okay, just double checking. Okay. Would you mind just sort of explaining again, tell me what's going on with you that brought you to the ER today?
I was diagnosed with COVID, and my doctor sent me to ER today for the simple fact that I have headaches and fever that wouldn't go away for the past 3 days. So he said it would be best for me to come to the ER and see if they could do a further evaluation.
And how long have you had symptoms of COVID?
Since Monday.
Monday, and today's Thursday. So Monday, Tuesday, this is day 4. And other than the symptoms that you told me, fever and headache, what other symptoms are you having?
Body aches, chills, and that's it.
Okay. Do you feel like your heart's going fast?
No.
Okay. Any cough, sore throat, runny nose?
None of that.
Okay. Did you lose your sense of smell or taste, or anything change?
The taste.
Tell me about that.
It makes the food taste weird, like, I don't know, like if you're eating metal or something. And so it doesn't appeal to you to eat anything.
Okay.
But I could smell it.
You can smell it though. Okay. Any abdominal pain, nausea, vomiting, diarrhea?
No.
Okay. No rashes?
No.
Okay. Now tell me more about your headache.
My headache runs from the front to the back, the whole top of my head, and it doesn't go away with anything.
How bad is it?
It's like a 10.
Okay.
Really bad, severe.
And it's constant?
It's constant. It doesn't go away with anything.
And then you had said the light makes it worse?
Yeah.
Does anything else make it worse?
No, just the lighting.
Okay. Have you ever had a blood clot before?
No.
And does your neck feel stiff?
No.
Can you bring your chin forward
Mm-hmm.
and then look up at the ceiling?
Yes.
Okay. And that doesn't hurt your neck?
No.
Okay. Do you feel short of breath?
You'll notice her
No.
vital signs here. Oxygen is 93% and her heart rate is 102. So 93% is a little bit lower than normal. Not in the danger zone, but a bit low, and her heart rate is a little bit fast, which again, we can see that oftentimes with a fever.
And you might be wondering why we asked her to bend her neck forward. When someone has fever and headache, one thing that we think about is meningitis, which is inflammation or infection of the lining that surrounds the brain and the spinal cord. It can be very serious. So anytime someone has fever and headache, we test for that. One way to test for it is to have patients bend their neck forward and kind of range the neck. If it's very, very stiff or they have a lot of difficulty moving it, it can be an indication that they have inflammation of that lining. It could be a sign of meningitis. We also asked her about blood clots because new information about COVID taught us that people are more likely to have blood clots if they have COVID. So this was something that we were concerned about for her. So we wanted to ask you all, if you were her, would you have come to the emergency room? Similar to the last patient, would you have come? And again, everyone is saying yes, of course, definitely. Everyone says yes. Okay.
I think when your doctor tells you you need to go to the emergency department, it's pretty compelling to go. And I agree with you. I think if you're having the worst headache of your life and you have COVID, and your doctor's telling you to go to the ER, those are all good reasons to come see us in the emergency department. We talked about this, neck stiffness, and did you talk about blood clots?
Yes, we mentioned the blood clots. Just a reminder that COVID can increase your risk of blood clots, and that's why we were asking her, had she ever had one? And we were kind of thinking about those symptoms for her.
So once again, let's go through the chest x-rays. This is the same normal chest x-ray, just as a reminder. And here is her chest x-ray. So it does not look nearly as bad as the last patient. And some of this variation in the black and gray can be due to how the x-ray was taken, the technique, sort of an overexposure versus underexposure, if you think about it like taking a picture. So this is not a very concerning x-ray. I don't know if it looks totally normal, but it's not concerning. It does not look like a severe COVID pneumonia to me.
And you noticed that her heart rate was a little bit fast. She was tachycardic. Her heart rate was over normal, over 100. And so we got an EKG. That's one of our indications for getting an EKG. And actually this EKG, I can tell you, looks pretty good. There's no significant abnormalities on this EKG other than a mildly fast heart rate. Because of her other symptoms, we were thinking about blood clots, and we knew that COVID makes you more susceptible. So we wanted to investigate that a little bit further. Anyone who has a fast heart rate and a low oxygen level, one thing we think about is a blood clot in the lungs. So we decided to get a CAT scan of her chest to investigate for a pulmonary embolism or a blood clot in the lungs. With her complaints of headache and knowing that she had COVID, she could kind of point to the specific area that she was having headache, which made us concerned that she might have a blood clot in her brain. So we obtained a CAT scan of her head, specifically looking at the veins, looking for any sort of blockage. And we're going to show you those now too.
Yeah, and I also want to add that the CT scan of the chest and the blood flow to the lungs, that one of the other reasons that was ordered was because her chest x-ray did not really look that bad, and it didn't really explain having an oxygen that was low, 93% oxygen with a normal chest x-ray, fast heart rate. Perhaps she has a clot in her lung, and that's the cause of her hypoxia or low oxygen. So first we're going to look at, this is going to be a quick scroll through the patient's chest, and the bright white areas are contrasts that are going to show us the blood flow just quickly here from the heart up the pulmonary arteries and going to the lungs. And we look for a disruption in that bright white. We look in multiple different planes for a disruption in that bright white, and that suggests a blood clot. That was normal. We did not see a blood clot there, thank goodness. And this is the CT scan of the brain. and contrast going through the veins of the brain. Again, looking for a disruption that would indicate a clot or a problem with blood flow through the venous system of the brain. And that is normal, fortunately. No clots in the chest, in the lungs, no clots in the brain.
And someone asked an interesting question. Someone said, if a patient with, does it increase the risk of blood clot while the patient has COVID or for the rest of their life? I don't know the answer to that question.
I don't know. Nobody knows. Nobody knows. So there's so much that nobody knows. I would think that this is something that goes on while you're affected with COVID. I did recently see a patient who had a very, very bad course of COVID in the ICU, had been home and had just recently stopped the blood thinners that he had been prescribed to prevent blood clots, and came in with a massive blood clot. So I don't know how long that effect lasts in the body.
And just so you know, someone asked what a blood clot would look like on those scans. Dr. Mason was pointing out the bright white areas. A blood clot would look like a dark black area, sort of in the middle of the white. It would stand out as a blockage. So we wanted to ask you, should this patient be admitted to the hospital? What do you think, as compared to the last person who did get admitted, thinking about this overall case? A lot of no's. No, 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 no. No.
I would like to, from now on, make my admission decisions based on Ask the Audience.
Yeah, great.
I think we have a very intelligent audience. If I could just poll 200 people really quickly, 300 people, see what everyone thinks. So I'm with you all. We did not admit her to the hospital, but there is one really important test that we often do for patients with COVID. So she had a very thorough workup. She had blood work done. She had an EKG. She had CT scans of her head and of her chest. We made her symptoms feel better. But remember, she has a low oxygen level. And so one test that we often do is we have patients walk around while wearing a pulse oximeter. And we see if that number drops with just some simple exertion of walking. We want that number to stay over 90%. So we call that a walking pulse ox test. We did that test and she passed. And so at that point, we felt comfortable that she could go home. She could come back if she felt worse.
And someone asks stress test, and sort of in a way, it's not actually a traditional stress test that you think of when you go to a heart doctor or cardiologist, but it is a way of putting the body under a bit of stress and seeing if it can handle it. So if someone can walk around and exert themselves and not have a decrease in their oxygen level, then we're reassured that they can go home safely. So yeah.
That's a summary of her course. And then I guess the last point we want to touch on is discharge instructions. So if we feel that it's safe for you to leave the emergency department, we want to have a conversation about when should you, what warning signs should you look out for, should signal to you that you need to come back to the emergency department. Dr. Werner is going to explain.
So we give people what we call return precautions. And everyone was saying kind of in the chat, well, if she gets worse, then she should be admitted. And you're absolutely right. That's exactly what we tell patients. If you go home and you begin to feel worse, usually what we say is to the point where you feel that you can't breathe without supplemental oxygen. That is a tip off. If you feel like you cannot breathe without extra oxygen, you need to come back to the emergency department. If you're having inability to eat or drink because you're just vomiting a lot or having copious amounts of diarrhea and you're getting really dehydrated, that would be a reason to come back. If you're so weak that you're not able to get out of bed or take care of what we call activities of daily living, cleaning yourself, cooking for yourself, bathing for yourself, those are reasons to come back. We tell people to make sure you continue to self-isolate because, as Dr. Vohra mentioned, this virus can take 5 days to show up or even 2 weeks. And once you have it, it can stick around for a while. We're not exactly sure how long people are able to catch the virus from each other. So we tell you to self-isolate, continue to wear a mask, don't go out into public for about 10 days. And we also tell people, unfortunately, you should expect to feel crummy. like you're not going to feel better for a while. And it doesn't mean you need to be admitted to the hospital. It just means that you do have something, you're sick, you have a virus, and you should expect to feel a little bad for a little while and take ibuprofen and Tylenol. Someone did ask if ibuprofen increase is unsafe during COVID. And this was one of the, I just want to address that. That was some false information that came out early on during the COVID course. It was something that was put out there really early and then was disproven. So it is okay to take ibuprofen, just so you know.
There are actually studies now looking at benefits of that class of medications as potentially being beneficial. So, and no one knows the answer to that. So don't go out and buy a ton of ibuprofen. No one knows the answer to that, but over-the-counter medications are thought to be generally safe. Acetaminophen or Tylenol, paracetamol, that's all the same thing. That's also safe, thought to be very safe, and will probably help you feel better from all the body aches and fevers that you may be having if you're dealing with COVID. And a final thought here, we alluded to this earlier, we're sort of in this vaccine trial period. And right now, the climate that we're in is so politically charged. And we, on top of this heightened sense of everything being highly politicized, there is a vaccine that is being rushed through all these trials as quickly as possible to try to get something out to the public. And that I could see causing a lot of concern and skepticism. And so my personal thoughts about this is that as much as possible, we don't want medicine to be the land of politics, right? Politics and medicine should be as separate from each other as possible. And unfortunately, they commingle so much. So we want to lean on science. We want to lean on science to give us answers about safety and efficacy of these vaccines. And if a particular political figure on either side of the aisle makes comments about a vaccine, please just take that with a grain of salt. They are politicians. They may have other motives, and you should be getting your information from science. So we want to take an objective scientific look at COVID and at vaccines. And if so-and-so says something about COVID or about vaccines, that doesn't mean you automatically dismiss that therapy or that vaccine. Let's lean on science together. And no matter what side of the political aisle you may be on, we hopefully can get through this together. I think with that, we're going to wrap up and turn it over back to Dr. Dillon if we even have time for further questions.
Thank you. That was really a good talk. Thank you very much. It seems like even from comments, everybody really appreciated going through the timeline and seeing examples and looking at patient perspectives. They really appreciated that. There are some questions if you're available to answer them. I think we can answer a few of them that I noted on the chat. One of the ones was, first few questions that came up was, what kind of mask is most effective? What about cloth masks? Are they safe? Are they good enough?
So I feel like Dr. Vohra would answer that question really well. So in terms of masks, there's different levels of risk. If I am seeing a known COVID patient, of course, I'm going to be wearing an N95 mask and a face shield or eye protection, the full PPE. If I'm going to the supermarket, that's a completely different risk profile. And so a standard mask or a cloth mask is going to be helpful, and probably that's going to be enough. So of course there are different types and styles of masks, and some are going to be more effective than others, but we don't totally know the answer about, bandanas versus the wraparound masks versus the ones with the filters. A lot of that's unknown. As long as you have a face covering, and you're having a normal amount of risk exposure, then a cloth or standard face mask is probably the right mask for you. And we definitely would want to encourage that you wear that when you're in public and near other people.
Yes. CDC actually recommends potentially for cloth masks to have 3 layers. They think that's the most, that's most effective for protection rather than 1-layer cloth masks, just because that's an extra layer of protection that you're getting potentially. So it's actually very beneficial. There were questions about people who come in with COVID. Do we order the same test for every single individual, or does it depend on the patient's health at that moment?
Yeah. Not only does it depend on your health, it depends on your symptoms, it depends on your medical history, your risk profile, the doctor that you're seeing. It depends on so many different things. So not everyone even gets a COVID test. I've seen patients that have all the symptoms of COVID and a known exposure, and there's really no benefit to doing the COVID test. You have COVID. Except for the purpose of public health and counting numbers, but really there's no benefit to that. And for example, I recently saw a baby, I want to say he was between 1 and 2 years old, and I talked to the parents and said, yeah, we could stick the thing down his nose and swab him, but he probably has it, and why put him through that?
Yeah, I agree. There was a question, what causes blood clots in COVID-19? Do we know?
It's not totally understood, but the thinking behind that, the theory behind it is that the type of cell that the virus binds to is a specific type of, it's a receptor that the virus binds to that lives on many different cell types in the body, certain types of lung cells and certain types of what's called endothelial cells. Endothelial cells line the inside of your blood vessels. And so it's thought to be related to that mechanism where it's causing an inflammation response on the inside of blood vessels, and that leads to increased clotting. That's speculative, but obviously backed up by good theory.
I like it. Just to summarize, would you mind just summarizing sort of when a patient comes in, how do you determine should they be admitted or should they go home? What are you looking at? Just in a summary, just a sentence or two.
You want to take that, Dr. Werner?
Sure. So the vital signs play a really important role. It's sort of the entire picture. Just to walk you through the way that we did it, we look at the patient. How are they breathing? How do they look? Can they talk to us in complete sentences? Are they able to sit up and do what they need to do at home? That's kind of number one. How do they look? Number two is looking at the vital signs. Is their oxygen level normal? Is their heart rate normal? Is their blood pressure normal? How do those things look, or how far off of normal are they? Once we order the labs, their EKGs and chest x-ray, we put everything together and try to get a sense of how things are looking. Are they showing us that they have signs of organ damage? So the first patient was having signs of stress on his heart, which is a sign of organ damage, and that's a reason to be admitted to the hospital. The second patient, her EKG was good, her studies, the CAT scans were good. She did have some abnormality in her chest x-ray, but she passed her ambulatory pulse ox. So ultimately, we put all of these things together and we say, do we think this patient would be safe at home? Would they be able to function well at home or not? And that's how we make the final decision.
Thank you. So as you can tell, it's not super simple. It's just like medicine, COVID is another thing that complicates things. And whenever we see a patient, there's so much thought process that goes into determining what are we going to do for that patient, not just for COVID, but any other disease process that they come in with. So thank you for all those great questions, and thank you for the great presentation. I really appreciate all the presenters today for doing this for us, and everybody else for joining us. That was really, really great. Next week, we're gonna have 2 other speakers who are gonna talk about emergency in air and on land. So that'll be something interesting to look forward to. I hope we're able to answer most of the questions. And if you guys have any last words, any of the presenters, please go ahead. But thank you very much.
Thank you all so much for having us and for being here and being interested.
Yeah, thank you. This is great.
Thank you, presenters. That was awesome. We really appreciate all of your hard work and your excellent information. I see in the chat, everyone is just adoring you. So thank you for being wonderful and taking the time out. We really appreciate it. You shared a lot of helpful info with us. So thank you so much. And just for the attendees, just so you know, this will be the same link that we use every single week. So you don't have to miss one. Just add it to your calendar. And we will see everyone next week. Thank you so much. Have a nice evening.
Thank you. Have a great evening.
Safe.
Take care.